So its management is quite lengthy, so I've split it into two parts. We will go for the diagnosis, in which, as you all know, that's the EULAR criteria which we are following it. More than 6 out of 10, if it's fulfilling it, that means the patient is having rheumatoid arthritis, in which certain points are for joint involvement, serology, then acute phase reactants, and the duration of the symptoms. Then comes the laboratory findings. First, we go for complete blood count to look for anemia, thrombocytopenia, and neutropenia if patient is having any Felitti syndrome. Then acute phase reactants like ESR and CRP, C3 and C4 levels. Liver function test to look for the underlying status, because we have to start certain hepatotoxic and nephrotoxic drugs to the patient. So renal function test and liver function tests are done. Then urine dipstick for the renal status. Autoimmune profile, as we are dealing with rheumatology, so ANA, RA factor, and anti-CCP antibodies. These are important. Then along with laboratory, we can go for the imaging, X-ray hand, X-ray cervical spine, if ultrasound to look for any synovitis, any crystal deposition or erosions. MRI can also be done. If patient is already on treatment and to look for the effects of steroids, we can go for DEXA scan. The X-ray hand, you can see in the picture also, there is certain soft tissue swelling, along with there is joint space narrowing, and you can see in the second picture there are erosions present, and periarticular osteopenia also can be observed. Then comes the treatment. Treatment for the rheumatoid arthritis, there are certain objectives, because it's a lifelong disease, so we have to continue the disease lifelong. So there are objectives like this. We should go for the reduction of inflammation, we should preserve the function, and we should prevent the deformity. For therapeutic response of the treatment, we follow a certain DAS28 score, and there is clinical disease activity index. DAS28 score, it is calculated by serving 28 joints, and here is the formula, you can check it. And if there is the score of DAS28 is less than 2.6, that means the patient is in remission. If 2.6 to 3.2, that means it's low disease. If more than 3.2, that means it's moderate disease activity, and if more than 5.1, it means high disease activity. So this is I will tell you in the end about the treatment involves, obviously, because it's a lifelong disease, you have to educate, you have to counsel your patient, and there is multidisciplinary approach involving the physicians, the rheumatologists, the occupational therapists, the physiotherapists, the surgeons, all are being involved in the management of this patient. So first of all, pain relief is most important, because patient, if is in pain, he needs relief. NSAIDs are the most important we are giving in rheumatoid arthritis. Then for starting with anti-inflammatory drugs, corticosteroids are first of all given, that is prednisolone 5 to 10 mg if multiple joints are involved. If a single or two joints of like knee are involved, we can go for intra-articular triamcinolone injections. We are giving corticosteroid because it's basically a bridging therapy to reduce the disease activity, to reduce the inflammation, as when we start DMARDs along with it. DMARDs are slow in action, they will take a certain time to show their activity. So for that time of period, corticosteroids they are given. Their IV steroids can also be given if patient is having certain very chronic or lethal involvement like pericarditis, or there is necrotizing scleritis. Then comes the DMARDs. They can be synthetic and biological. First of all, we will see for the synthetic, the most important, and which can be said that it is the drug which is used mostly and started with this drug, is the methotrexate. That is 7.5 to 10 mg and maximum up to 20 mg. Obviously, it is effective for rheumatoid arthritis, but it has many side effects, including it's hepatotoxic, it's it causes pneumonitis, can cause pulmonary fibrosis, gastric ulcerations, cytopenias, and if long-term taken, it can cause lymphomas too. If patient is having symptoms and more side effects, then we can start with folic acid 1 mg per day after methotrexate to decrease its side effect. And if patient is having too much of hepatotoxicity and cytopenias, we can give antidote, that is leucovorin 2.5 to 5 mg. So this methotrexate, it's contraindicated if patient is pregnant, if GFR is less than 30, if patient is alcoholic, and patient is already having any liver disease or chronic hepatitis B and C. It should be avoided with trimethoprim, sulfamethoxazole, because both can lead to bone marrow suppression. Then it is also avoided with probenecid and amoxicillin, because it increases the dose of the intensity of the levels of methotrexate in the body, and that can lead to more bone marrow suppression. And because it's a toxic drug, so monitoring is very important in this. Full blood count monitoring, then after 1 to 2 weeks, then every month for 3 months, and then 3 monthly. Then liver function tests are done every 4 to 12 weeks. Renal function tests are done every 3 months. Then comes sulfasalazine, that is given in 500 mg BD. It can be given up to 3 grams. It also has side effects like neutropenia, thrombocytopenia. If patient is glucose 6-phosphate dehydrogenase deficient, it can cause hemolysis, and it can affect the spermatogenesis, so it can have fertility issues in males. So it also needs monitoring, like complete blood count for 1 to 2 weeks, then monthly, and then 3 monthly. And yes, then comes the leflunomide. Leflunomide, in which 100 mg for 3 days, that is the loading dose, and then 20 mg per day. It also has side effects like diarrhea, rash, alopecia. It is also hepatotoxic, and it is also teratogenic and avoided in pregnancy. Plus, its metabolites are seen in the body up to 2 years. So pregnancy should be avoided up to 2 years. If we want to wash out from the body, the cholestyramine can be given for that purpose. That is the antidote, you can say, for the leflunomide. Then anti-malarials like hydroxychloroquine, that is the most common, which is being used for mild rheumatoid arthritis initially, along with methotrexate in the form of HCQ. That is from 200 to 400 mg per day. And however, for a patient is taking for the long term, it can cause retinal toxicity. So after 5 years of use, every year monitoring of the retina is important for it. Then comes the Janus kinase inhibitors, in which there can be tofacitinib, baricitinib, upadacitinib, and this most important side effect in which is it can cause to lead infections and heart-related events. Then comes the biological DMARDs, in which first of all are the TNF inhibitors, which includes, you should be knowing the name, and at least the dose of infliximab is important. In which etanercept, infliximab in 3 to 10 mg per day at 2, 6, 10 and 4